afternoon, everyone, and welcome to this TNT session sponsored by Edwards Lifesciences. We really have an exciting session today because with a title like this, Reinventing the Treatment of Patients with Tricuspid Valve Disease, it can only be exciting and innovative. What we're going to try and do for you as our objectives is really take you through some of the patient selection, how we look at patients and think about the anatomical characteristics when thinking about the full portfolio of devices that Edwards Lifesciences offers for the tricuspid valve. We want to show you how those options differ from each other and maybe how you can apply them to your patient. And then also, I think we're all very excited that in Europe you'll have the PASCAL precision system. I say this because I've had a chance to use it already in the United States, and it's really been impactful in my practice. So hopefully it's going to impact your practice just as much. To do the session, we have a great team. My co-moderator, Philipp, Lurz, and this amazing panel who I'm going to use my list so I don't get anybody's name incorrect. Obviously, Niklas, Schofer, Jörg, Hausleiter, Volker, Rudolf, Andreas, Rück, and Mirjam, Keßlerr. I got it right, thank you. And we also have a great procedural analyst, Nina Wunderlich, who, when everything's really difficult, Nina makes it easy and understandable, so I'm sure she'll do that. And we also have a chat master who's joining us. So maybe, Philipp, if you want to tell them about the chat.
Yeah, so dear colleagues, we really warmly invite you to put forward all your questions, your comments. As you've seen and heard, an excellent panel. Take the chance. Ask them what you want to know. Do this either via the app or directly and go to the microphone. But this is all about us interacting with you.
And it's about patients and discussing treatment approaches to patients. So the best place to start is always with having a case presentation. Andreas, if you can take us through the presentation of today's case that will form the basis of our discussion.
So I think this patient represents a fairly common patient, which presents with TR, an elderly lady, 83 years of age, presenting with dyspnea, initially also with edema, multiple valve diseases, a TAVR treated in 2020, pacemaker implanted after that, then a mitral tear in 2021. She has a persistent atrial fibrillation and some, I think, minor coronary artery disease not requiring treatment with intervention. She is on a quite substantial heart failure medication. As you'll see, it's a quite complete list, including a rather high dose of furosemide, as you see, which is equivalent to maybe 150 milligrams or something of furosemide. So it's a quite ambitious medical treatment that was instituted to treat her symptoms, but there were remaining symptoms despite this. If we first think about the surgical option, which might not be the first thing to come to mind, but still should be considered, I think, in some patients, if we go to the TRI-score calculator that was developed in France, as you know, and published about a year ago, we don't have too many points, but still we get a point for age over 70, functional class 3, high dose of furosemide or equivalent furosemide, and the slightly decreased LV function. It gives you 5 out of 12 points, and that actually gets you a 14% predicted in-hospital mortality. As you know, this is a score that is developed specifically for tricuspid surgery. Then on the right heart cath, performed about half a year ago, you'll see a moderately elevated systolic PA pressure, a wedge pressure that's also a little bit elevated. The cardiac output is not too bad, and you'll see that the pulmonary vascular resistance is actually low, and the RA pressure not too elevated either. So maybe not, from this you cannot really derive that there is a torrential TR or something like that, since the RA pressure is not that high. But you'll see it usually falls into the acceptable range of patients where you would expect that you could derive a benefit from treating the TR. On an echocardiogram, which was done recently before the procedure, we see a mildly reduced EF, a normal-sized left ventricle, just mildly reduced right ventricular function with a TAPSE of 19, so almost normal. Both atria, as expected, large, which is very common in this population, and as you know, very high prevalence of atrial fibrillation in this population. The previous...
Afterwards.
No, I mean, I think, we want this to be as lively as possible, and discussion is important. So I think there's something you have a question about. Let's address it now.
Well, I had a question about the previous slide on the TRI-score calculator, because you didn't activate the right-sided heart failure signs in the tricuspid patient? So no edema, no
Mirjam
ascites,
has seen
nothing?
the patient.
Yeah. According to the definition, we don't have severe edema, we don't have ascites or anything like that, and that's why we didn't check that point.
Only mild symptoms of right-sided heart failure.
Exactly. And,
Okay.
You're smiling.
Yeah, we could debate if the score should be even higher. I agree on
Then
that.
it would be
Yeah.
Even higher.
To
Yeah.
make it even more difficult, the GFR is exactly 30, so we are on borderline there too. So it's at least 5. Let's call it like this.
I guess most people would say it's probably not the first option to go for surgery for such a patient.
Absolutely.
For sure. Let's see, coming back here, going through the echo findings, both the previous valve interventions show a good remaining result, with a good result after a TAVR, good result after mitral tear last year, and the PA pressure measurements are the same more or less as on the right heart cath. So unchanged despite diuretic treatment in this half year between these two investigations. Now going through the TOEs, this is transgastric picture, and I think the right picture should be, it's a slow motion without color. You can appreciate where the color is. It's mainly, I would say, central between the septal anterior and a little bit towards the posterior too. It's a little bit hard to see where the pacemaker lead is, I would say, but it's probably up between the posterior and the septal leaflets as I see it here. But you see it a little bit in the central part there too. It doesn't seem in my eyes, but I think we get more detailed analysis on it later. The gaps don't seem to be really big. The checking on the result of the mitral tear, no problem there. This is transthoracic echo just to assess the size of the TR, and you might see that the vena contracta was measured to around 9 millimeters. Now the procedure starts, and this is intraprocedural TOE with transgastric again, showing more or less a similar pattern to before. We can discuss, I think, the details of this, if it's a good candidate for TEER or for some other kind of tricuspid treatment, so I won't go into detail on this now. More transgastric imaging showing again the pacemaker lead being up in the posterior commissure mostly. And here we have vena contracta measurements, which I think are around 9 millimeters still, maybe a little larger. I think the PISA was measured a little larger than 9 millimeters on this imaging. Okay, thank you.
Thank you. Thanks, Andreas, for the case. So I think we have a brief minute or so to talk about if there's any information missing from this case for you to make a decision what you're going to offer this patient. I think we all agree it's a high-risk surgical case. The TriScore is probably under-evaluating this patient's risk. And that it's a patient also that really reflects how our field has changed, I think. Here's a patient who's at a TAVR, then a mitral edge-to-edge, and now we're considering doing a transcatheter tricuspid procedure. And I think many of us 5 years ago wouldn't have thought we'd be seeing so many of these patients where we can do and help them with doing multiple procedures. So maybe very briefly, Niklas, in your practice, what would your thoughts be about this patient?
Well, first of all, I think we've seen everything we need to see of this patient. I think right heart cath is very important to perform that in these patients to rule out precapillary pulmonary hypertension. And as you said, it's a typical patient with tricuspid regurgitation, elderly, a female patient with more or less preserved ejection fraction AFib. And regarding the morphology of the valve, I'm not so sure if the septal is maybe split into two parts, but for me it looked more like a three-valve tricuspid valve. So I think a good candidate also for edge-to-edge therapy, at least a good candidate for tricuspid intervention, I would say.
Yeah. Jörg?
May I? So I have, although we're in a tricuspid session here, some points. I'm wondering about the low right atrial pressure, just around 8 millimeters of mercury in a typical tricuspid patient is rather low. Mm-hmm. The other aspects about the anatomy, it's not a simple case. We have the pacemaker lead in there. for me, it looked like more like a quadricuspid valve and not a regular tricuspid valve. And for me, the main jet was more posterior located, and we know from Philipp's and our work that the anteroseptal TRs are much more easier to treat. So I would assume that there's going to be quite some difficulties in this posterior part to address the jet. So I would think this is a very complex case.
Okay. So I think, you guys highlight something that's really important, is that delineating the anatomy of the tricuspid valve can be very challenging, where I think I've been on multiple panels where we discuss, is it 3 leaflets, is it 4 leaflets, because there are times that can be very subtle, the indentations, and certainly that does impact our outcomes. Mirjam, you know the patient. Any sense from you about what the anatomy is?
I think we will come to that later.
Okay, so let's not take away from that. I did want you maybe to address one of your points, ask everybody else to address one of your points. I think most of us would agree, right heart caths, we're all doing them, they're really important. And for me, they're very important about understanding pulmonary pressures, understanding is pre-capillary versus post-capillary. I just wanted very briefly someone's experience about the utility of right atrial pressure. Does it always reflect that that patient needs treatment or not? I mean, have you seen patients whose right atrial pressures are like this one, but they still have severe TR that needs treatment? Philipp?
Yes, I mean, obviously it depends on TR, but it also depends on right atrial compliance, or the compliance of the overall venous system, and that makes it a little bit more difficult. There is some data suggesting that when you see a drop in right atrial pressure after the procedure, that's a good sign, and I would agree, but there are also some patients where you don't see that, and that doesn't mean that they can't benefit. So in easy words, it's always good when you see a drop, but if you don't see it, you still don't know what to make out of it.
It's a useful tool, and we're going to stop there. What about, Volker, what about annuloplasty? I mean, is annuloplasty an option in these patients? Can you take us maybe through who are the patients who benefit from tricuspid annuloplasty?
I mean, I think we heard that it's not a straightforward case for edge to edge, so this is really a relevant question. And from the images I saw, this patient had not so much ventricular tricuspid regurgitation, so there was not so much tenting, tethering, which is something that always drives us away from cardioband. Maybe to have a look at the slides here, I think this here really nicely illustrates a 3D work, echo work from Milano, that, well, secondary TR, and the main mechanism of it is mainly annular dilation. And I think if you compare the normal tricuspid valve to the ones on the right side, pulmonary hypertension, left heart disease, and atrial fibrillation, you see how massively dilated this valve gets. And I think that's even can more clearly be seen if you compare it to the mitral valve. I mean, it's just another dimension, and it's not clear to me that automatically the same thing that works on the left side is always the right thing on the right side if you compare just the simple size of these valves. I think the point for Cardioband is it addresses the main problem. I think this is made clear. It's also a plus of this therapy that you have future options open. So if it doesn't work, you can always take a second step. And it's a very standardized procedure. You do CT planning if these are suitable patients, and you adapt what you do very much to the anatomy of the patient. And I think this is something we discussed now already of the 4 different types of tricuspid regurgitation we have. I think the patients we look for when we do Cardioband is atrial tricuspid regurgitation without tenting, and I think this could be indeed a suitable candidate here. So this is also from the PCR tricuspid focus group paper, which I can only recommend for everyone to read. And if we look specifically now at where annuloplasty should be performed, I think we are very much in this situation on the left here, where we have not a very large gap central to posterior chat location. It's probably not as important where the chat is for cardioband, and very mild tethering. So annuloplasty is an option that is, I think, equivalent to TEER, and this is then also a standalone therapy. And the other advantage we have in more advanced patients, if the gap is larger, you can start with annuloplasty, and then you have the option to then do edge-to-edge repair. So.
Yeah. And I mean, what about annuloplasty in patients who have a lead across their valve where the lead's not interfering? Can you treat those patients with annuloplasty too?
Yes, so I mean, in all the studies, we see the percentage of patients with leads is between 15 and 30%. And I mean, it's important to look for it. If you have real impingement, then you would probably remove the lead first, have a micra implanted, for example, and then do annuloplasty.
Isn't one of the advantages of cardioband the fact that it doesn't matter if it's tricuspid or quadricuspid? We can forget about Becker's classification and just worry about decreasing the annulus? Is that too much of a simplification?
Well, it is simplified, but there's, of course, some truth in there. On the other hand, during a TEER procedure, we already see what we're getting. But there's a big difference to the annuloplasty device, where we're anchoring these 17 anchors, what's currently usually the case, and then only at the end we're going to see, when we're cinching, what kind of TR reduction we do get. And then there's not really much we can do to improve the results. With an edge-to-edge repair, you can replace the edge-to-edge, the clip device, the PASCAL device, put it in a little bit different location. So you have much more options to work on the valve and try to get the perfect result.
Philipp, you had a comment?
I just wanted to add that conceptually the main difference is really that obviously with the cardioband you still maintain all the future options, and because you don't interact with the leaflets, you could still do what's needed thereafter, and that's a potential advantage which should not be forgotten.
But this patient is 82 years old. How many procedures should such a patient get? Well, I would be happy if I'm 82 if I just get one.
That sounds very ageist. Come on. But I mean, I could also argue that one of the nice things about a cardioband procedure is it's the same every time, right? You know, you have to start here, you have to go from A to Z, and you have to put these however many anchors depending on the size of the annulus. And a edge-to-edge procedure is different every single time. Because even though you walk into the procedure, we've all done this, and we said, okay, I'm going to put one here, one there, at this angulation, and then when you put that first one in, you don't get what you were thinking you were going to get. So you have to change sometimes what you do in the procedure. There's a lot of decisions that get made in the procedure, whereas cardioband, I go from A to Z. Every time it's the same.
So you wanted to have it simple?
I love simple. Because you know what's great about simple? Simple means other people can learn it and do it and get the same results. And I definitely want simple. Well, I think most of you talked about edge-to-edge. And there's a lot of edge-to-edge sort of experts here. But maybe, Jörg, you want to take us through really what's the evidence for edge-to-edge interventions in TR now that we've seen the data for annuloplasty?
Yes, thank you. What we're going to share with you is a little bit what we're going to show also in this conference. Mirjam, my former colleague, will share this, and this is the PASTE registry. PASTE is an investigator-initiated registry which we came up a couple of years ago, where we contacted the sites. Currently there are 18 European sites who are performing edge-to-edge repair with a PASCAL device on the tricuspid valve. And so far we were able to collect more than 500 patients retrospectively, and a subgroup of those patients already have a 1-year follow-up. And this is what we are reporting today. And all of these echoes were centralized and analyzed, in central core lab analyzed, if you will say so, and we have a follow-up rate of around 81%. And what is really intriguing is that what we see initially, that from patient group which has 90% severe torrential or even massive or torrential TR, that you can really reduce this TR grading to 1+ or 2+, so mild or moderate, in about 80% of patients. And what is new, at least from this registry, that these data appear to be very durable in the first year. And this translates also then into clinical improvement. You see again on the left side the New York Heart Class before the procedure, with almost 90% having either New York Heart Class 3 or 4. And at 1 year follow-up, about 2/3 of patients are in New York Heart Class 1 and 2. And this is what we're really seeing in daily clinical practice, that the patients are benefiting so much from those procedures. Is also represented in the 6-minute walk test. You see the increase by 43 meters, but also in the decrease in the quality of life score. In this case, it's the Minnesota Living with Heart Failure questionnaire with a top of 12 points, which is quite considerable after 1 year. And we are dealing with elderly patients, as we see in this patient, 80, 82, 83 years. And for those patients, it really matters that they have this improvement. And that's what we really can show.
Right. So, Jörg, maybe just a couple of other questions. Thank you for being brief. Can you maybe talk a little bit about what the procedural success was in PACE overall, and also what procedural times were? And the reason I bring it out is that we were in the late-breaking session yesterday, where we saw some of the first data from the US and from the CLASP TR study in the roll-in patients, where these were centers, some of them who've never done tricuspid procedures or had done only off-label procedures and using PASCAL for the first time. And so I wanted to give the audience a sense of when this is commercialized and you have experience, what is the expected success rate and how long does the procedure last?
We do not have, we have not collected the procedural times, but of course, there is a learning curve with any device. Most of the sites who are participating in PACE have already some significant advantage also with the competitor, with the TriCLASP device. So there is a significant experience in Germany, in Europe, with an edge-to-edge repair on the tricuspid side. And the procedural times right now, I would think, are somewhere close to 45 to 60 minutes for the entire procedure. So very well comparable to a mitral case. It all depends on the imaging quality. Echo is much more demanding as on the mitral side, and this is mainly the driver of longer procedures if it takes longer. What we're gonna get today is what we have just seen before, that in the majority of patients, in 80, maybe I go back actually, that in 80% of patients really get down at discharge to a 1+ or 2+ TR. And I skipped that due to the time, but if you go back see on the right side, that there's quite a significant proportion where we were able to reduce in this 5-grade scale the TR by 3 grades. This was around 20%. Really a massive decrease in the TR, and then by 2 grades in already 40%. So this is quite significant, and even if you only reduce by 1 grade, the symptomatic improvement is considerable in most of those patients.
Philipp.
Maybe let's go back to clinical benefit once again, because there's a question about primary hypertension and whether you use at home in your program at your institution any specific cutoff values, either for PA pressures but also for the differentiation between pre and post capillary primary hypertension. So is there a cutoff value where you would not consider patient for treatment? Maybe.
Regarding the pulmonary pressures, it's really hard to determine a limit, I think, because I always have an eye on the pulmonary vascular resistance, which is much more important to me. So I would rather accept a systolic pulmonary artery pressure of 70 in a patient with a PVR below 1. That's fine with me, but it's not true for PVRs above 3. So I think you have to take into account not only the pressure but also the resistance.
What about you, Jörg? You do a lot of right heart cath in these patients. What's your cutoff?
We're, again, very similar to what Mirjam just said. We are looking also at the pulmonary vascular resistance and the transpulmonary gradient, which is more or less the same. If we're identifying a truly precapillary pulmonary hypertension, then we're very careful in our consenting of the patients, because then the expectations for the patients should be different for such a procedure. They are much more sicker, they have a higher mortality, although those who are surviving still have a benefit from the stretch repair. I think we need to be clear that in those patients with precapillary pulmonary hypertension, we should fix first all the pulmonary diseases, and if then the TR still persists, we could discuss it with the patient.
Is there a transpulmonary gradient cutoff? Because I want to give the colleagues something that they can use, because when they're in their own lab, give them some cutoff.
15 millimeters of mercury on the mean pressures between PA and
wedge. Yeah.
And wedge is something we look for.
So once you see a transpulmonary gradient greater than 15, I think most of us are more concerned,
12, 15,
more cautious.
Yeah.
Doesn't mean we won't treat the patient, but we start questioning how much benefit there is, and we try and get a pulmonary hypertension expert involved maybe to see if there's anything we can do to optimize that. Niklas, real-world data is really important, such as PASTE. Are there other data we can look forward to?
Thanks for asking that question. Actually, instead of showing you data, I will give you a little teaser maybe, as we will present the 6 months data of the ongoing TriCLASP study, which is a post-market study evaluating the safety and efficacy of the PASCAL system for treatment of TR tomorrow here at London Valve. So anyone who's interested might join this session. But I guess I can already reveal that I guess the data will add some evidence to further support this kind of treatment or the concept of it.
Right. So this is a prospective registry sponsored by Edwards. Does it have a core lab?
It has a core lab, and it's a very strict core lab, I must say. So there is a core lab, but of course, I think such registries as led by Professor Hausleiter and the PACE registry, really IITs, sort of are also, I think, very important in this field, that we become a little bit more also independent, also from industry-sponsored studies and registries.
Great. I think having a core lab is really important to help our understanding of how effective we are. Niklas, one of the exciting things I think about PASCAL is the precision. I was lucky in the context of the clinical study in Europe to use it. Maybe you can tell people what precision is.
Yes, for sure. So PASCAL Precision is the latest iteration of the PASCAL platform for treatment of MR and TR, and I guess everybody knows that the system consists of a 22 French steerable guide, and then there is a steerable catheter, and inside that there is an implant catheter over which the implant then is brought into the tricuspid valve. And when you take a closer look at this system, you see that it already looks a little bit different from the previous version. There are many adjustments and modifications have been made. All of those actually aim at the catheter, so not the implant. That remained the same compared to the previous version. And maybe in summary, for me, the most important modifications are first the hemodynamic valve of the guide sheath. I think this has been refined, and now it really reduces the amount of air you aspirate once you put in the implant catheter. I think that's one important thing. And then I think for most of the users, very important is this laser cut hypotube technology of the implant catheter, which reduces the friction between the implant, the steerable catheter and the implant catheter, and that really improves. Probably that's what you meant, the responsiveness of the catheter, also the stability. So I think that's for many users maybe the most important improvement. Then you have this redesigned handle. You see that, which now allows for leaflet grasping by advancing the sliders irrespective of the clocking. or the rotation of the handle. So that's also, I think, a small but smart improvement. And also the release has been modified and it's now hidden behind a cap. You do not interact with the release mechanism. So that's the modification which have been applied on the catheter and the implant. I think everybody is familiar with that, has not changed. You still have the ACE implant and the PASCAL implant, or also called P10. It has its nitinol-based closing mechanism. You have the elongation feature. You have the independent grasping. So that's, I think, the same. And yeah, I can share a case we treated in Hamburg where we briefly also typical. It's a male patient. That's probably the only thing which is untypical, but otherwise I think it's a typical tricuspid patient with massive TR. You see the transthoracic echo on top, and then pretty tough imaging regarding the transgastric short axis view, but you see more anterior and central localized regurgitation. You also see a pacemaker lead in the posterior septocommissure and a very wide jet. And just very briefly, we treated this patient. Actually, my colleague did this, Dr. Kalbacher, very nicely with two implants, one quite anterior in the anterior septocommissure, and then a second device which was very easy to navigate there. And then you see here on the bottom left the grasping of the septal leaflet, and then the final result in the transgastric view, and also in the RV inflow, only mild TR and discharge echo. So I think it's a nice technology. It improves ease of use, the precision system. So that was our experience, at least.
Philipp.
Niklas, do you have any experience with mixed or primary TR?
Yeah, we did some cases. Those cases, from my experience, we had two cases, and were pacemaker cases of patients who had an extraction of a pacemaker lead and then a flail of the posterior leaflet. And these kind of pathologies, I think, are quite good to treat. You have to start anterior and then go more posterior, but you sort of have to close in the posterior septocommissure. So I think that's possible. If I think about Hedinger syndrome, patients with really restrictive leaflets, I think this is probably not the right technology, and I have no experience in treating these kind of patients.
Another question relates to the issue of gradient after TIR. How often is it, and what would be your cutoff value?
So our cutoff value is 3, but it's more a gut feeling, and we also try to individualize this a little bit. If we have a patient with a borderline, for instance, precapillary pulmonary hypertension, we believe that a gradient is probably worse than a patient who has no pulmonary hypertension. So we maybe then we leave a little bit more of the TR, but we don't have any data supporting this. I think we really need evidence. I think there's data that the gradient does not play a big role, but the gradient also differs from patient to patient. We know that from the mitral space, it maybe depends also on RV function or pressure in the RA and RV. So I'm not so sure if the gradient alone is a good parameter, but 3 is the cutoff for us.
Yeah, I think it's interesting how our concept of this is continuously changing. I mean, years ago, if you'd asked us all, what gradient would we accept with secondary MR, we'd all give you a value, and then we see all these analyses coming out from COAPT showing that maybe slightly higher gradients in secondary MR may be acceptable, maybe less acceptable in primary MR. And I think we're going to see the same with TriCLASP, but I think Jörg knows, I think there's an analysis from TriValve looking at the gradients and their impact in mortality. And in that context of that study, we've not seen a huge jump in mortality with gradients. I'm not saying we should now put 5 clips into everybody and get their gradients to go to 10, but we may have a little room, a margin of error that's a little bit larger than we initially thought. You had another question, I think. Yeah?
No, maybe the only thing I would add is that potentially the remodeling and the reduction in RV size could be more than what we normally see with mitral interventions. So you should always be aware that when you end up with a gradient of 3, it could be 4 or 5 1 month later.
Right.
And that's something we've seen. But overall, I do agree. It's obviously it's a moving target.
And it's a safety margin. If you end up with 3 and even have 4 or 5, apparently it does not have a significant impact. So I think we should not go probably above 5, because then at some point, of course, we will have some symptoms.
Yeah, yeah. And I think I've been very surprised with this implant, how when you release the implant, you know, what you saw before you release is usually what you get, or slightly better. So Niklas, I think you summarized it pretty well. The implant's the same, but we have a delivery system that's more stable, it's more reproducible. You can actually take your hands off the table and talk to the echocardiographer without having to hold on to everything. One of the things I really like too, and I don't know about, well, I'd love to hear your comments, Jörg, is, you know, and you're the one who taught me this, I give you credit, you know, is that often for tricuspid, you need to grasp one leaflet and then pull over and grasp the other leaflet. And so even the way, you know, the clasps, the way they move now, and the access to them is much easier, allowing you to do that in a much better way.
Oh, absolutely. And if you allow me, then I'm going to also share a case where I just present that in detail.
There
how we're going to do this.
I didn't know that.
You didn't know? Okay. So this is actually a case which we did do with a precision system as a live case broadcasted to China. And as you see in this image, and it's going to run in a second, it's also a patient where we have a quadricuspid valve, a pretty complex mitral tricuspid anatomy with a lot of cords, especially in the posterior region, and a pretty big hole in the middle, a pretty big gap. And when we looked at this patient and put it on the table, I was not very sure that we can treat this patient. We thought that we're going to do a 2-device strategy into the anteroseptal line of coaptation, which is shown there, but then also probably addressing the posterior part with a different device. What I really want to highlight, and this is why I think the precision system is so important, is that that sometimes we are underestimating the chordal structures below the leaflets. And it can be very, very complicated with these devices to really navigate underneath these leaflets, especially if you have such a fan-like structure as you see here. And if you want to really grasp the posterior leaflet, then it's going to be difficult, and you need a device which really functions very precisely as you want to do this. So in preparation, you saw this very big gap, and what I want to share with you is what we are doing if we see such a big gap at the time of the procedure. And this is now playing with sound, I guess. Yes, I'm going to start this. Yes. Now what you're going to see is that I'm going to tilting the table. That we're going into a position of 10 degrees table tilt. It's a reverse Trendelenburg position, which results in a venous pooling in the lower extremity, and which will result in a decrease of the annular size of the tricuspid valve. Furthermore, and now we need to our colleagues from anesthesiology, is the second thing what we can do is that we can increase the PEEP pressure during the ventilation. The PEEP was around 5, and now we're going to increase this to, let's say, 14, 15 in this range. And as you see, while we're doing this, the gap size is getting significantly smaller, and this will facilitate our entire. So this I wanted to share with you, because in this case it was really very nicely to see that with two very simple strategies in the procedure, you can help yourself make the procedure much more easier. Tilting the table if you have this table possibility, and increasing the PEEP pressure reduces in the reduction of the venous flow. to the heart, and then the gap size is getting significantly smaller. But then, if we go into the procedure, that we, as I said, we were trying to grasp the anterior leaflet first with an independent grasping, as we just had. And what you're going to see in this transgastric view now, how we're pulling back the PASCAL device, how we're immobilizing the anterior leaflet onto the device. And now when we see this, that we have a good capture, now I'm putting down the clasp of the anterior arm so that we have captured this. And now in the next step, we're going into the deep esophageal view. And on the right side, you will see how I'm trying to engage with the septal leaflet now, that we're really going to the hinge point of the septal leaflet, so that we have a complete septal leaflet into the device. It's shown here with the pointer, and then we are grasping this leaflet as well. I think we can go on. And now we turn back into the video where we see how this device is being closed in the transgastric view, and you see how the tissue bridge is evolving. And then we have a very good coaptation in this anteroseptal line of coaptation. You see it again, and now we are adding also some color, and you will see, although the transgastric view is not the very best view to assess the color, but you see already that the jet has significantly been reduced. And then we were adding another device into the posteroseptal line of coaptation, and I'm going to jump that to the end so that you just see what we obtained just on the left side. You see in the 3D, the big coaptation defect over the entire line of coaptation with a significant color jet on the lower image. This is how the two devices were then finally placed, with almost a trivial mild TR at the lower mid 3D image. Again, this is the 3D, this is the transthoracic before the procedure. And at 30-day follow-up, we still had this very perfect result, and the patient improved significantly. I think the precision system, especially in this case, where the anatomy was so complicated with a big coaptation gap, helped us significantly to treat this patient effectively.
Yep.
Jörg, this is clearly a patient according to all sorts of consensus papers and reviews. This is a no-go patient. This is a red patient, right? And you achieved an excellent result. How can we educate ourselves to understand who isn't that red but actually becomes green with a few maneuvers?
Good questions. I think we need to study this much more carefully, and this was also when I was addressing these questions yesterday, that when we're reporting such studies as the TriCLASP study, as also the PACE study, probably we need to discuss much more what kind of anatomical characteristics we included, how big was the gap size at the maximum position, the gap size where we placed the devices, how many leaflets were there in reality in a core lab-based analysis. Only then we can assess what kind of results we're getting and what is the best strategy then for the individual patient.
I think it was some great tricks, as usual. I always learn from you. My table doesn't do reverse Trendelenburg, unfortunately, so I might have to have someone hold. No, I'm kidding. But we do use the PEEP a lot, and I think the PEEP's a great adjunct to make your procedure easier. The one thing, maybe as another trick, if you could share with the audience, when you showed us those first transgastrics, there were a lot of cords. And that can be sometimes a big challenge, getting between the cords so that you can grasp. Any tips you have for the colleagues, what you do? I mean, clearly we only use ACE because of that. We don't use the PASCAL, but any other tips and tricks?
Yeah, you're raising another very important point. What I'm doing in such a case, I'm elongating first the device, going into the RV, and then very slowly and very controlled going into the 180 degrees position, and always looking that we're still in the same clocking position, that we're not rotating the device, do minimal adjustments so that we really get up to the point where we're then at 180 degrees.
Excellent, thank you. I think we're all doing that, but I want to highlight to the audience that everybody thinks about the elongation feature as a feature only to get yourself out of trouble when you're stuck in Cordy, but more and more, we're actually using it as a feature to enable grasping in some complex anatomies too. If there are no more comments, I think we've seen the array and the possibilities for our patient, whether that be an annuloplasty, whether that be edge to edge with the precision system, the PASCAL precision. So Nina, maybe you want to take us through a little bit the procedural analysis and discuss the strategy and procedural plan for this patient.
Thank you, Azeem. So I had the chance to look a little bit closer at the valve morphology. You just had a couple of seconds to really look at the valve features. I'm not sure if you can get the smart screen images on the big screen. Is that possible?
We're going to have to do it over here.
So otherwise it's very difficult for you to see. So we have still frame images, and according what I have seen during my analysis, so we have a 4-leaflet valve. So we have an anterior leaflet over here. We have a P1 here, and we have a P2, and we have a septal leaflet. So this leaves us with a 4-leaflet valve, and this might be a little bit more complicated than just treating a 3-leaflet valve. So another thing, if you look at the gap size, so we had 2 major origins of the tricuspid regurgitation. So one is more to the central part, closer to the anterior and septal leaflet here, and the next one was extending here to the posterior part. And if you look at such a morphology, which leaves us with a 4-leaflet configuration, as you can see in this red bar here on the red side, and you add an anatomical factor like a larger coaptation gap, which is not that big here. The gap is not the problem in this specific case, but we have a TR jet origination, which is extending to the posterior part. So this gives us an additional morphological factor that we have to take into consideration. And if you look at the results, if you have such a constellation, this would bring us to a scenario where you have to expect a residual tricuspid regurgitation in up to 45% of the patient. In the specific case, I wouldn't think it's that high because the gap size is not that big. And what we've seen and what's on the positive side, we don't see a lot of tethering. So the amount of tethering was very small in these patients. So let's come to the next slide. Okay, so let's speak a little bit about the strategy. So if I looked at the case, I had the impression that it might make a lot of sense. You have 2 jets, 2 major jets. One is more to the middle of the valve. So my impression would be maybe start with a device in this region here, but you still have this posterior origination of the jet, so this is something you should address. And you might think you need a second device maybe in this region. So just have a look what's positive in this case. What positive criteria do we have? So I think what's positive, we have a really nice length of the septal leaflet. This is something you have to grasp, and this is really nice. What's also really nice, we don't have a lot of tethering, and we have a gap size which is not that big. So it's in between 5 and 6 millimeter. So this is definitely on the positive side. Another thing, the pacemaker lead is positioned here in the posterior septal commissure, and it's not involved in the mechanism of tricuspid regurgitation. So I would think we don't have to think about too much to think about the pacemaker lead. So this is also on the positive side. We also might have some negative aspects here in this scenario. So what might be negative? So a 4-leaflet tricuspid valve is more complex than a tri-leaflet tricuspid valve. You might have to put 2 clips in here, as I've already mentioned. This would be my first strategy here. What's also maybe worth to mention, the posterior leaflet here, the P1, which should be connected to the septal leaflet here, is a very long leaflet, but it's not very broad, so it might be very difficult to grasp that leaflet. There was another thing which wasn't really nicely shown, but the pacemaker lead, there was a pacemaker lead in the atrium which really made a big loop, and it was in the course nearly parallel to the mitral valve. So the pacemaker lead was not involved in the mechanism, but if the course of the pacemaker lead is really parallel to the mitral valve, you may have an interaction here with your devices. So this would be my concerns. And there was another thing, because we heard that the patient had a TAVI prosthesis in place, the patient had a mitral procedure in advance. So this might cause shadowing, which can also affect the imaging quality during the procedure. So in summary, I would think, coming back to what Jörg Hausleiter said, well, it's a 4-leaflet valve. We have 2 major originations of the jet. I think you would need 2 devices here to adapt and to cover all the lesions we have to cover. But in my eyes, it's not a very simple procedure because of this very specific scenario that I just addressed.
Nina, thank you. That was a fabulous analysis of the case. And I think also, even though, Jörg, you showed us that now with PASCAL Precision, it's a single operator procedure, we have to remember we can't do it without having a great imaging partner who guides us and tells us where to do these procedures. And Nina just showed why. Thanks, Nina. I think let's see the case.
I just have a question?
Sure.
So all these factors we rely on, gap size that is unfavorable, multi-scalloped, etc., they were actually developed with older generation devices. So is it still valid, or are we doing better than what we think from the predictors?
Good question. I think we're getting better, of course. So we're learning from each procedure. But on the other hand, I think we also need to be careful. There are boundaries, and the more we're going closer to the boundaries, we will see that the results are not that perfect in the long term. So we are learning. Yes, we can do more than we could do 3 or 4 years ago, but we cannot treat every patient. We need to be very clear.
And I also think, that group of patients that are maybe sort of yellow, whether they're green or red is also very much dependent on operator experience, imaging, and how many you do. The more comfortable you become, the more challenging cases you're able to take on. But a lot of those guidelines we also put so that our colleagues who are starting out doing this can start with the procedures where they're going to be successful, and we can make sure these procedures are reproducible.
You missed the imager experience.
Absolutely.
We all would love to have Nina in our labs. Huh?
We all would. So I know there's some questions from the previous presentation online and on site. I think we're going to try and finish the case, and then we'll come back and answer all the questions. Is that okay? Perfect. Yeah.
Yeah, so we will now jump into the procedure. So we are already located in the right atrium with the PASCAL Precision ACE, and the first thing we do is a really moderate gaining of height maneuver by rotating the guiding catheter counterclockwise and the steerable catheter clockwise, just to make navigation a bit easier, that we don't interact with the tricuspid valve. And the next step is to check the path by moving the implant catheter, which you can see here now. We're actually quite happy with the pathway so far, and so the next step is now to go into the transgastric view, which you can see here now. You can see the tip of our PASCAL in the short axis view at the left, and you can see that we're still above the valve on the right. We have to keep an eye on that. What we now did was rotating the paddle knob and opening the device. And now we are positioning in the anterior septal coaptation line, where we put in our first device. As we just heard, we are rotating the implant catheter, and this is where we're ending up. Just to show you again, we've just done that, but we have to check the clasp, so we have to be sure which slider belongs to which clasp, and as we know that we can proceed and advance the PASCAL Precision into the ventricle, so just underneath the tricuspid valve, which you see here now. We usually advance through the valve in the transgastric view just to make sure that we stay in the position we wanted, and that just happened. And now we will perform the clasping. We do an independent clasping with the lateral leaflet first. We have some shadowing here due to the ventricular lead, and we have already clasped the lateral. And now we have performed the Tarzan maneuver to the septal, and now the septal clasp is also down, and we are rotating the paddle knob to close the device. We are back in the RV view, RV inflow-outflow, to assess the residual TR. And for me, the most important thing is that we don't have any residual TR anterior to the device, which wasn't the case. And we have a gradient of 1 millimeters of mercury, which is also good. And this is the position we achieved. Our plan was to be just anterior to the papillary muscle, so as central as possible, and I think we have achieved that. You can also see the leaflets in the device. And now we are releasing the device. You can see the redesigned handle on the upper left image. We have removed the cap, and underneath there are the suture locks, which are now unscrewed, so the two whitish caps, and it's pulled out, and the same is true for the second suture lock. And the last step of the release is now the release knob, the blue one. It's also rotated, and you can see in the fluoro the release of the PASCAL A's. Now the steerable catheter, the implant catheter are retrieved. We usually fix the steerable in that position and advance the guiding catheter, so the guiding stays central in the right atrium. And so this is the result after the first PASCAL. We were quite happy. That's exactly what we expected. We have a central to posterior residual TR. And that's what we are planning to address with the second device. It's also a PASCAL Precision Ace, as you can see here. We are here just double-checking if we are interacting with one of the pacemaker leads. And as Nina just said, the ventricular lead is just crossing the valve with this loop, and then it makes the navigation a bit more tricky, but we didn't have any interaction. So this is the next step, and you can see that I applied too much flex to the steerable, so the pathway you can easily see on the fluoro image, so the pathway isn't ideal. And I was also located too much anterior, so I pulled the whole system and pulled the steerable to go to the posterior side of the valve. And now I'm checking again the pathway, but still the pathway isn't as good as it should. So there's some further unflexing of the steerable here, and it's becoming better. Bit pulling to go posterior, and now we're approaching a good pathway. So the next step is to open the device in a capture-ready position and check the clasp, as we did before. You can see that here we have to rotate the implant a bit. We do that with the fluoro because we have the other device implanted yet. We can have a look at it and orientate. So this is the clasp check again. And we actually did the clocking in the transgastric view, which you just didn't see. Sorry about that, but we come to that in a second. And this is again in the independent clasping, first of the lateral, as we just did before, and then of the septal. So again, Tarzan maneuver. I wasn't too happy about the septal because I think it rolled, and you have to avoid that. So I'm improving the insertion there, so it doesn't roll. And then we switched to the transgastric view, actually to close the device. But what we've already seen is that the lateral, so the P1 isn't really in. So that's why we just lifted the clasps, we are a bit repositioning there. And if we don't have good visibility of the P1, as we just had in the RV inflow-outflow, then we usually switch to the grasping in the transgastric view. And I really wanted to go as posterior in the P1 segment as possible, but as Nina just said, it's not that broad. So, you can already see that on the P1 segment, the posterior part is already immobilized due to the pedal. And now we go into a capture-ready position, and we will perform the clasping in the transgastric view. So now the capture-ready position, 180 degrees, and now the slider is going down, and we have just captured the P1. Actually, we wanted to achieve a rather 2:30 clocking than the 3 clocking we just did, so I'm rotating a bit towards the 2:30, but we usually don't do great movements after we have already clasped the lateral. And you can also already see that the septal is already on the pedal, but we had good visibility of the septal leaflet, and that's why we switched back to the RV inflow-outflow view to get a really good view on the leaflet insertion. So the leaflet is already on the pedal, but we don't know how deep because I pulled up a little bit too much. So this is the septal leaflet, and we're doing the clasping now of the septal leaflet. You have seen the clasp coming down, but I think I thought we should improve it, just go back really to the hinge point of the septal leaflet, what we achieved now with a second attempt. And we are closing the device, and this is the result we got. But we weren't sure about the tissue bridge of the P1 because there's some mobility anterior to the device, and that's why we decided to do the grasping of the lateral again. So what we did, we can discuss that. We lifted both clasps. So we could have kept the septal, but I usually don't do that because it doesn't really make much sense to me to the kind of reverse Tarzan. And so this is the third and hopefully final grasp. This is again the transgastric view where we usually close the device, as you can see now. And you can see that we have a nice tissue bridge between the P1 and the septal. We do have some residual TR, which originates posterior to the device and also a bit between P1 and P2. So yeah, we thought if we could improve that, but didn't really have a good idea about it. So this is the residual TR we had. And as we didn't have any great alternatives, we thought we would accept that. But if you have suggestions, we can discuss it, obviously. So we are unscrewing the suture lock again of the PASCAL precision. And then the blue release knob, as we just did before. So this really changed from the Gen 1 to the Gen 2. And now this is the release. And again, we're fixing the steerable and unflexing and advancing the guide so that we are central in the right atrium. So if we want, we can also do another device. So this is the final result. We have the gradient was 1 millimeters of mercury even after the second device. And this is the final TR we got. So this is the maximum we had. And to sum things up, this was the discharge echo we had. It was obtained 2 days after the procedure. Really searched for the largest jet, which you can see on the left. And yeah, so this is the final result. Yeah. So.
Mirjam, thank you. There was I think, a great result. I think you also showed us the challenges of, doing edge to edge. You have to be prepared to adapt your strategy. You have to really make sure you have good leaflet insertion. I may have missed it. What was the final gradient?
It's 1.
1.
Yeah, okay. It was just 1 half
Fantastic.
second in the...
So maybe if we can go very quickly around the panel, we also have some questions to answer, so maybe we'll ask the first 3 of you. Any thoughts on this procedure? Would you have done anything differently? Any tips and tricks for the audience? Niklas?
Well, first of all, congratulations. I think a very nice case. And so in the end, it turned out to be a pretty complex case, as Professor Hausleiter thought already. So I think it's once you've closed the anterior septal commissure and there's still residual TR on the posterior septal side, then always it becomes a little bit difficult, and many times I think we get a little bit disappointed about the final result, even if you treat the posterior septal commissure nicely, because you do not have this annuloplasty. So that's maybe also a little bit my learning from my previous cases, that and also something we should maybe better predict how much residual TR will there be once the anterior septal commissure has been closed and completely treated. And with respect to the independent grasping, we do it the same. We all use independent grasping every time. And once we're not sure about the lateral leaflet, we let go of the septal leaflet as well, because you're too engaged to the septal leaflet. I think re-optimization of the lateral when you're still stuck to the septal is not possible.
Jörg, some tips and tricks, some comments?
Very nice outcome. I think I would not have assumed that it's just going to be like that at the end. I thought it's much more complicated. We saw another aspect that with all those devices, the aortic valve, the mitral probably not that much, but also the leads, that the image quality significantly deteriorates the more devices are in the heart. And this makes all those tricuspid procedures much more complicated. This is a risk factor which we're not really looking at in all our discussions up front, the number of devices. What I liked a lot is, compared to Nina's drawing, is the position of the second device. I would also have thought that, as you did it, that the posterior device should be the maximum posterior side of this P1 segment, so that the P2 can co-apt from the side to the device. And this is, I think, what the beauty of this result is, that there's almost no residual gap then between the P2 and the device to perfectly solve this complex issue.
Volker, would you have done annuloplasty?
I still think it would have been a good option, because you probably would have gotten a comparable result, and without any further procedure, which the data have also shown. So it would have been an option still after seeing this, but I mean, I congratulate you to this excellent case. I mean, this was perfectly solved, I think.
Yeah, challenging case. So we have a few minutes. Philipp, there were lots of questions that we couldn't get to earlier on the previous devices and presentations. Let's maybe try and catch up with them.
Yeah, so one burning question is about afterload mismatch and what's happening with RV function once you reduce TR, and whether the differences for repair and replacement. Obviously, this is a very complex issue, but it needs a discussion because it's so important. Anyone feeling obliged to contribute here?
Well, the RV function always is lower after the procedure, because before the procedure, the RV, as well as on the mitral side, the LV is in hyperactive state. It works more than it really needs to do. And if you're reducing the regurgitant volume, then the RV function normalizes it. It really doesn't drop to lower values. It does drop to lower values, but this is what we need to expect. But as long as we are selecting patients, I think, with a low pulmonary vascular resistance for those therapies, I don't think that we will see a lot of acute right heart failures. I think this is why right heart cath and the characterization of those patients is so important.
May I add something? And we can also state that we don't see right heart failure at this point in time. Looking at all the different therapies for tricuspid regurgitation is an extremely, extremely rare thing to happen at all.
Even in such great cases, we don't see it.
The only caveat I'll say is it's because we've gotten better at case selection. All right?
That's what I'm saying.
When we started doing valve replacement years ago with the Navigate valve, we didn't have that. We did have patients who did poorly and went into acute RV failure afterwards, but we didn't know what we were doing. So case selection and patient selection always is fundamental in making sure you have good outcomes. There was also a question, I think, about device thrombosis, and are we seeing thrombosis on these devices? I've not seen any with the repair devices or annuloplasty.
Yeah,
so we
at least for the repair devices, we don't see any thrombosis. I fully agree.
So I'm going to let Philipp really finish up the session, give us the key learnings from the session. Thank you, Phil.
Okay, so to wrap up, I think that first of all we've learned that we are in an extremely comfortable situation, because we not only keep on learning about TR, about RV function, right heart failure, but we also can envisage that in the future we will have multiple different approaches to treat TR, with a huge potential to tailor therapies to the specific anatomy. We've seen that all the sophisticated thoughts put into the anatomy are not just nice thoughts, but they have some action. They impact the strategy. We can do multiple grasping maneuvers with a precision device and see that it's safety and can be very effective. Annuloplasty still has the huge potential benefit of being the most physiological repair. Thank you very much for your interest, for your interaction, and obviously thanks to the wonderful panel and the great case. Thank you.
Thank you.